My name is Dr. Marjmin. I'm the pediatric surgeon and a lecturer in our faculty of UKM. Today we are going to talk about our CPC is seeing through a crack. You guys may be wondering what is the crack. Okay, in medical, usually we use a crack is a fissure. Okay, so can you guess what the disease that has a fissure? Anal fissure, okay. Because of surgery, right? Anything else related to the bowel if there is a fissure? Okay, we are going to talk about inflammatory bowel disease, which is not a very common disease in our part of the world here. But it's a very important topic that you may need to know and you need to familiarize as well. Even though we are not seeing that often, but we do have patients that needed to be managed. So for the speakers today, we have Dr. Asmarina, which is our master student in pediatric surgery UKM. And Dr. Erica Wong Hing, which is our pediatric radiologist, which is also a faculty member of medical UKM. And Dr. Muhammad Hafiiz, which is a master student in pathology. And we have a special guest from Hospital Tuanku Azizah HKL, which is Dr. Ong Sik Yong, which is a pediatric gastroenterologist. Okay. We are going to have a presenters giving their talk, and in between that, we may let you guys ask questions in case that you needed to clarify further. So without further ado, I would like to invite Dr. Asmarina to the floor.
Okay, Assalamualaikum and a very good morning everyone. I'm Asmarina, pediatric surgery trainee. For today's CPC, I will be presenting on the case presentation. Okay, this patient, CYJ, 8 years, 5 months old, Chinese boy, born full term via spontaneous vaginal delivery with birth weight of 2.7 kg. Antenatal and postnatally was uneventful, immunization up to age, and there is no history of hospitalization before. He was initially referred from a private hospital in view of severe malnourished with superior mesenteric artery syndrome, unsure of diagnosis and for stoma management. In October 2022, he presented to a private hospital with complaint of right iliac fossa pain for 2 days prior to admission, and he was referred from ED there as acute appendicitis. It was associated with fever and loss of appetite 1 week prior, and he also had history of hand, foot, mouth disease 1 week prior. He presented at that time with multiple oral ulcers, fever and poor appetite with loss of weight about 4 kg. He took treatment at a private clinic and was given antibiotic. Otherwise, there is no vomiting, no abdominal distension, no altered bowel habits or loose stool, no URTI or UTI symptoms, no skin rashes, and no history of abdominal trauma or surgery before. And there is no family history of tuberculosis or inflammatory bowel disease. At that time, clinically, abdomen was soft and there was mild tenderness over the right iliac fossa. Impression was made less likely appendicitis and proceed with ultrasound abdomen. Ultrasound abdomen was done and reported as query appendicular abscess with possible appendicolith, then proceeded with CT abdomen which showed pneumoperitoneum. He then underwent laparoscopic converted to open laparotomy with ileostomy on 25th October 2022 intraoperatively, noted multiple operation at the terminal ileum. Bowel looks healthy and not dilated, and there is moderate contamination. And this is the intraoperative finding. Appendix looks slightly inflamed, possible due to contamination, and there is moderate contamination with localized pus collection. And there was multiple perforation at the terminal ileums. There is 4 sites of perforation. The rest of the bowels is normal with dilatation of the terminal ileums. Post-op, he had poor weight gain despite no issue in the oral intake and stomach loss. 1 week post-op, he had persistent vomiting and repeated CT abdomen showed superior mesenteric artery syndrome. Then he was referred here for further management. For further history, there is no history of PTB contact, no recurrent or chronic GI losses, no recurrent or chronic skin or oral lesion, no recurrent respiratory infection, no recent travelling, no other family members having similar symptom, and there is no family history of IBD. For past medical and surgical history, there is no history of hospitalization and any surgical intervention before. The child was well and thriving. No concern raised during neonatal period and throughout the childhood. Regular follow-up with his private pediatrician, and he completed immunization as per national immunization schedule. For family and social history, it was non-consanguineous marriage. Parents are well and healthy. Father is a sales officer. Mother is a merchandiser. He is the youngest of 2 siblings. The elder sister is healthy. There is no family history of malignancy, diabetes mellitus, prolonged cough, chronic GI disease, example IBD, or skin or oral lesion. For diet history, his taking adult diet included green vegetables, not a picky eater, taking meals 3 times per day with a good portion and amount, no known allergies, no chronic GI losses or skin or oral lesion associated with diet even since neonatal period. For physical examination, he was alert, cachexic, not syndromic, not septic, or in distress with good perfusion. The lung is clear, CVS dual rhythm no murmur, per abdomen soft, not distended. The laparotomy wound at that time is clean, no gaping and no discharge. For his progress in HPKK, he was transferred to HPKK on 2nd November 2022 with an Hickman catheter, OGDS, and nasojejunal incision. For the OGDS finding, basically normal finding, esophagus was normal, stomach normal, mucosa seen, and there is no ulcer. Duodenum D1, D2, and there is no ulcer seen. We started TPN on 3rd November 2022. Day 12 post-op, noted laparotomy wound gapping with pus discharge. Day 14 post-op, the laparotomy wound dehiscent with sloughy base, and this is the wound on day 47 post-op. There is presence of anterocutaneous fistula with minimal splus, but the base is healthy. And there is presence of a peristomal wound gapping with minimal slough. On the ileostomy side, we noted that there is multiple ulcer at the mucosa. This is 10 weeks post-op. For the laparotomy wound, we can see obvious anterocutaneous fistula with granulation tissue and minimal slough. Peristomal ulceration with sloughy base. Because of the worsening peristomal ulceration and the wound, discussion have been made and we proceed with OGDS colonoscopy and GIT biopsy on 5 January 2023. Okay, basically on OGDS, the esophagus was normal, stomach mucosa hyperemic, but there is no polyps or ulcer. D1, D2 duodenitis appearance. The biopsy, multiple biopsy taken from the stomach and also the duodenum. This is the colonoscopy taken. We scope through proximal loop. The ileum appeared normal. Scope from the rectum. There is mucus plugs and old feces. And we able to scope until the hepatic flexure, unable to proceed beyond due to angiocoagulation. The bowel mucosa grossly normal. No ulcer, no skip lesion, no polyps or mycin. Multiple biopsy taken from the colon region as well as from the anterocutaneous fistula. This is the latest wound on 18 May this year. The laparotomy wound, we can see healing with wound capitalization with anterocutaneous fistula. But for the peristomal wound, we can see the ulceration with irregular age, unhealthy granulation tissue with moist sloughy base. For the weight progress for this patient, this child had difficulty in gaining weight despite on TPN and optimization of oral intake. This is him during the pre-illness with weight of 15 kg, BMI 12.4. This is during admission to HPKK, cachexic with BMI 10 kg. And this is the latest picture of him this month with BMI 10.3. We can see this is the growth chart of him. we can see the BMI of pre-illness of discharge is below third centile. Okay, the lowest BMI when he was admitted to HPKK is 10. During admission, despite nutritional optimization, the latest weight we can get is 14.4 kg with BMI 11.7. The latest weight during our TCA is 12 kilogram. For investigation, this is summary of the investigation had been taken in HPKK and also from the private hospital. Stool calprotectin, which taken outside, is low, which is used to detect inflammation of the intestine and is one of the marker for the inflammatory bowel disease. Stool samolelasen also negative, TB workout negative, anti-nuclear DNA low titer, low antibody titer, which is not usually associated with autoimmune disease and may be found in normal population. Other connective tissue investigation like anti-double-stranded DNA, C3, C4, rheumatoid factor was negative. Full blood picture show normal chromic normocytic anemia, no blood cell seen, and the latest RFT and LFT taken at us in January was normal. And that is all for me. Thank you.
Okay. If you guys notice that the history is a bit atypical of the inflammatory bowel disease. When they first presented, basically, what we are worried about at that time is whether appendicitis, which also the presentation is not typical for appendicitis. Okay. Usually appendicitis, you will get a right leg fossa pain with fever. In this boy, he had fever previously, but there is an right leg fossa pain, but there is no fever at the time of presentation. So that's the reason for the multiple imaging, which usually for the appendicitis, we don't go for imaging so much if it's a typical presentation. Okay. Even intraoperatively, usually for the inflammatory bowel disease and TB, you will have a changes in the bowel appearances. So in this boy, he doesn't have that. So that's make it a bit more difficult in terms of trying to make a diagnosis. The original diagnosis that was entertained at that time is basically infective causes like typhoid or other infective causes, which that's the the investigation was sent and also negative. Okay, so when you have this kind of patient, you have to go by the clinical history. What are the possible diagnoses? And then you try to tie that with all the investigation and also by the intraoperative findings. And all of that are basically quite atypical. Okay, and for a child to have a severe malnourished despite in the hospital with the TPN, so it's a bit worrying. Okay, it's like, despite you are taking a lot of food, I was joking with the mother that, if it's in a Malay culture, we call it a saka. No matter you banyak you makan pun, still you kurus kan. But in this boy, it's a bit worrying because in children, we need them to grow not only for the health issue and also for the brain development issue. Although it's more important in neonate, but it's also important in children. So these are the reason why we bring this discussion so that you can see from the imaging and from the HPE, the finding are also not of a typical inflammatory bowel disease. So you have to learn what are the typical presentation first, then you can see why are the dilemma and the problems in managing this patient. Okay. Without further ado, I would like to invite Dr. Erika to show the image of this boy.
Thank you, Ms. Marjmin. Okay, good morning. I'll be presenting on the radiological part of this patient. So we have several sets of imaging study. It started off with ultrasound first. There was one, I think there was one X-ray, but the X-ray was not really helpful, and the X-ray was done actually after the ultrasound. So this ultrasound image shows dilated bowel loops, right, with some mildly thickened wall, circumferentially mildly thickened wall. And this view here shows likely the ileocecal valve, which is dilated, surrounded by the cecum, which is also dilated. Okay, so the only findings from this ultrasound was some thickened bowel loops with thickened ileocecal valve, which is rather non-specific for any pathology. So we can only conclude that there is some kind of enterocolitis. Entero is small bowel, colitis is large bowel inflammation, okay? But it doesn't tell us the cause of it. So this was done on the same day. This is a CT scan, okay? The CT scan was done because of reasons that there was an emergency. There's a obstruction, clinically obstruction with an unknown cause. So what we see here is, this is axial soft tissue view, and this is contrasted study. So we could see a thickened cecum with a thickened wall, and this is the ileocecal valve region with terminal ileum coming off from it. So terminal ileum is also thick. Normal bowel should be somewhere around like this. Yeah, so this is very thick. Okay, the enhancing part is actually only the mucosa. The thickened wall is the darker one outside. So thickened cecum with ileocecal terminal ileum and ileocecal valve. And when we look at the coronal view here, you can see that there are multiple dilated bowel loops. Okay, small bowel loops, not thickened, but they are dilated and fluid-filled. This part of the bowel loops will not be seen on X-ray because they are fluid-filled. You will only see the bowel loops that contain air on X-ray. So X-ray is not a very good modality, okay, in children who have fluid-filled bowels. And over here, there is transition zone seen actually from dilated bowel to a non-dilated bowel, and the terminal ileum actually is all collapsed. So this transition zone tells us that there is some sort of obstruction at this point, but we didn't see any mass over there, okay? And other findings, the yellow arrows are actually pointing to free air within the abdomen, which represents pneumoperitoneum, okay? You shouldn't see all this free air around the stomach, below the liver and all this. On here, this is the lung window, okay, to help us pick up the free air. So these are bowel loops with free air fluid levels, but in between the bowel loops, you see some free air. So this is pneumoperitoneum. When you have pneumoperitoneum, we suspect bowel perforation. Okay, so conclusion from this CT was pneumoperitoneum, suggesting that there is some kind of bowel perforation, but we couldn't see the site of perforation. Multiple dilated fluid-filled small bowel loops with transition zone means that there is distal small bowel obstruction. And this may be due to adhesion or a stricture because we didn't see any mass that is obstructing, okay? And the thickened terminal ileum and the thicker wall indicates that there is enterocolitis, but it is non-specific. It doesn't tell us the cause of it. So imaging differentials from that, based on the thickened ileal wall, are infective enterocolitis, which is more common than the rest, okay? So they can be bacterial, viral, or TB. In this case, we couldn't really tell because there's no specific features to support. So sort of like TB, apart from the thickened wall, sometimes you can see necrotic nodes, which suggests caseating granulomas, okay? So we didn't see those in this patient. There are only some enlarged mesenteric nodes, which is not necrotic. So, and the inflammatory bowel disease is one of the cause that can give rise to this appearance, but it's not common in children. And enterocolitis due to vasculitis can present similarly. Then this patient had another CT scan done about 1 week later post-op, okay, because patient was not well and there was some kind of obstructive symptoms. So this coronal CT shows that there is a change in the caliber of, this is duodenum, the second part and the third part of duodenum, and you look at the distal part of the third, D3 lah, okay, the third part of duodenum, there's a sudden change in caliber. So when you look at sagittal view, the angle between the SMA, the superior mesenteric artery, and the aorta is actually quite narrow, 21 degrees only. Normal should be more than 25, okay? Yeah, so it's less than the minimum allowed. And the distance between the SMA and aorta is also borderline narrow. It's 9 mm. Usually anything below 8 mm, we consider it as very narrow. And other than that, we also see dilated small bowel loops in the abdomen. The cecum here is still, and ascending colon are still thickened and very, and are collapsed actually, all right? So this view again shows, this is SMA in axial, SMA and aorta, and this is the dilated third part of the duodenum, and you can see that there is a waist, a narrowing in the middle as it passes over. So SMA syndrome or superior mesenteric artery syndrome means that there is a narrowing between the SMA and aorta and causing compression to the third part of the duodenum, leading to some sort of like obstruction. So patient will have vomiting because it's a proximal obstruction. This happens usually in patients who had a sudden weight loss, okay, severe weight loss. So conclusion from this CT was multiple dilated small bowel loops, which would either represent intestinal ileus from the operation itself, or there is a distal small bowel obstruction, but we couldn't see a transition zone in this case, in the second CT, okay? So mildly dilated proximal D3 with small aortomesenteric angle and borderline aortomesenteric distance raises suspicion of superior mesenteric artery syndrome. This should be tied with clinical signs, then only the diagnosis can be confirmed. It shouldn't be diagnosed on imaging alone. So MRE was done. MR enterography was done around 2 months later. All right. So the MRE shows that there is persistent thickened wall in the terminal ileum. So these are the terminal ileum, and this is actually the enterocutaneous fistula that opens into the air. So you can see that there's a defect over at the skin region. So you have fistulas coming off from the terminal ileum to the skin. And this view again shows the same thing. It's all the fistulae going on. And this view here shows the thickened cecal wall. And in this MRI, the bowels are actually not dilated. Okay, not dilated. So, and the other sequences, this is T2, showing a very short segment of thickened mid-transverse colon wall. And on DWI, there is some mild restricted diffusion seen, which usually means that there is some kind of active inflammation going on. So conclusion from this MRI is enhancing bowel wall thickening at ileocecal region with a suspicious skip lesion at the mid-transverse colon, multiple enterocutaneous fistula, which was also seen on a clinical examination, all right? So this is confirmed already. And the no stricture was seen in this MRE. And we conclude this as most likely an active early onset inflammatory bowel disease, and most likely Crohn's disease because of the skip lesion and also because of presence of fistulae. So early onset IBD or inflammatory bowel disease is a combination of can be Crohn's, can be ulcerative colitis, or IBD unclassified. Okay, there are 3 groups of them. In children less than 10 years old, UC is more common in less than 6 years, and Crohn's is more common in more than 6 years old. Both present with more colonic disease compared to adult, and isolated ileal disease and strictures are less common in children. Okay, less common. less common compared to adult. So how do we image suspected IBD? Imaging is actually complementary to endoscopic assessment, and it is used primarily to assess small bowel, which you cannot access, you cannot reach with scope, okay? Yeah, so the part of the small bowel in between the ileum, which you cannot scope, we use imaging to help assess that part. So ultrasound abdomen is usually the initial one that you are going to use to screen, and the MRE is the gold standard, okay? CT is discouraged in children because it has high radiation. But as in this case, in cases where there is surgical emergency, you have peritonitis, you have bowel obstruction, you have perforation, then it can be used in times of surgical emergency, okay? So other than that, the diagnosis should be reached by ultrasound and MRE. So how to choose which one will be the best? You need to consider patient acceptance, sedation, need for sedation, invasiveness, radiation exposure, and quality performance of the diagnostic test. Abdominal X-ray has very limited role, okay? Bowel in children is often filled, as you have seen in this patient, and it can be grossly dilated, yet you don't see it on abdominal X-ray. You only see air fluid dilated bowels. Fluid-filled ones, you cannot see them, okay? So they have low sensitivity also for bowel thickening or perforation. So we don't really use them for diagnosis of IBD. Fluoroscopic studies are highly effective in demonstrating mucosal irregularity and luminal narrowing and do not require sedation, but however are discouraged because they also have radiation. So when we have better imaging that can give us more information without radiation, like MRE or ultrasound, we don't usually use fluoroscopic studies, okay? So they are reserved for problem solving. When the standard imaging cannot give us a definite answer, then only we may try resorting to this. So this here, we talk a little bit about ultrasound. It is radiation-free, non-invasive, low cost, and you don't need sedation. So it's very easy to do. Just need the skill, okay? So it is used in initial screening and the disease activity monitoring as well, okay? Very useful for disease activity monitoring. It can assess for small bowel inflammatory symptoms like thickening, okay? And also complications. So we assess wall thickness, we assess surrounding inflammatory fat. Vascularity is usually increased in inflammation, okay? And the peristalsis, this is something that not all the imaging will give you, because ultrasound is real time. You can see the bowel moving. And the lymph node enlargement, you can also assess for abscesses and fistulae. So the images here shows this is normal, okay? Normal bowel, and you see multiple layers of different echogenicities. So they hypo. So this is normal, not thickened bowel. You compare to something that is abnormal in a Crohn's child, this is thickened, and also you don't see the layers that well. They lose the layering effect, and it's very hypo-echoing. And when you put on color, you see a lot of color coming up because it's inflamed, right? So all this information tells us that there is inflammatory reaction going on. Drawback of ultrasound includes difficult visualization of deep bowel segments, because if there is air in front of the bowel, then you wouldn't be able to see what is behind it. So the limitation is in that, okay? When you have a lot of air fluid bowel, you cannot see what is deeper. You can only see the most superficial ones. And also it depends on, it's operator dependent, depending on the skill and also experience of the operator. MRE is the gold standard, okay, for diagnosis and also for monitoring for IBD. Sensitivity is 84% and specificity is almost 100%, which means if the MRE is normal, completely normal, it's almost likely that you are not dealing with IBD, okay? So specificity means the true negative rate is actually 100%. Assessment of the it can assess the entire length of the small bowel, okay, and which is not possible by endoscopy. And it helps distinguish Crohn's disease from ulcerative colitis because it can help define the location, the extent, and the severity of the inflamed segments. It can also help characterize and separate inflammation from damage. Okay, inflammation are those things like increased vascularity and thickening, which usually only requires medical management. But anything that goes on to damage, which includes stricture, fistulae, or abscesses, then this would most likely require surgical management. Okay, yeah. So like in this patient, it's already perforated. And this DWI is a diffusion-weighted imaging, which is one of the sequence in MRE. And this sequence, if it is restricted, it helps to identify areas of high inflammatory activity. So it's useful in helping us detect which part of the bowel has high inflammatory activity. And it also can demonstrate not only small bowel, but large bowel also. It has, if the colon is abnormal, it can also show, all right? And sometimes even perianal disease, we can see it, yeah. And you can do a dedicated pelvic MRI to assess the full extent of perianal disease. So it is also used not only in diagnosis, but to monitor disease progression and treatment response. So these are some of the images from literature showing the classic findings in Crohn's disease. And you can see here, this is a loop of thickened bowel, small bowel, eccentric. This side is thicker than the other side, and it's very enhancing because the normal bowel wall is over here. Normal dilated bowel is over here. This is very thick and very enhancing, all right? And then at the same time, you see a lot of strands enhancing tubular structures going into the midline. These are actually dilated and very engorged vasa recta, the vessels, okay? So we call this comb sign, your comb, okay? Comb sign, which is a classic finding described in Crohn's. So our patient didn't have this, okay? So if you see this, it's highly suggestive that this may be Crohn's, all right? So thickened bowel enhancing means very hypervascular and all this comb sign here. And this is another patient with already a collection next to a very thickened terminal ileum. So this is already abscess formation. So MRE can help show all this, okay, together, and fistula, like what I've shown in our patient, right? But there are some technical challenges in MRE, and it's actually quite difficult to get very good images, okay? Because patient actually need to take a very large amount of oral contrast. It's 20 ml per kg over a span of like 1 to 2 hours. So children, you can imagine, it's not easy to get them to cooperate if they don't want to drink, okay? So, and another problem is the long scan time. MRI usually takes at least half an hour to up to a few hours, okay? It depends on if the patient moves persistently in the gantry, then you need to drag on longer to get a diagnostic image. So, and also, very small children, you cannot ask them to breath hold. So there will be a lot of breathing artifacts if you don't apply the respiratory gated to help minimize motion artifact. So all this together, most of the, not most, but a lot of times you may need general anesthesia. If not, you cannot get image that is diagnostic, right? So this is a technical difficulty compared to ultrasound. So take-home message is ultrasound and MRI are the mainstay for imaging investigations of IBD. Ultrasound is used for initial screening, okay, and the disease monitoring as well. And MRE is the gold standard in the assessment of the extent, full extent of disease, and also disease monitoring. So CT should only be reserved for emergency situations. Thanks.
Any question for Dr. Erica? A bit too overwhelming. Okay. I would like to ask Dr. Erica regarding SMA syndromes. Is there any specific imaging that is better than CT scan to look at the SMA. SMA is basically what happened is that when in between the superior mesenteric artery and superior mesenteric vein, there is a bowel that goes behind that. Okay, when you had significant weight loss, there is no fat in that area, which makes the two vessel compressing on the bowel, so the child cannot tolerate feeding because of that.
Imaging actually, usually the first one that we will go to is ultrasound, because ultrasound can also give you the information of the angle between the SMA and the aorta. So it's not just CT scan. The one that we had earlier on was CT scan, but ultrasound can also give you that information. So most of the time when the patient is referred to us for SMA syndrome, we will do ultrasound first, okay? And we will also most of the time be able to see the dilated duodenum going narrowed and then passing as it passes through between the SMA and aorta. Unless there's a lot of air and we couldn't displace the air that obstructs the view, then only we will resolve to either CT or MRI to diagnose. Yeah, so most of the time, if you have clinical suspicion of SMA syndrome, get an ultrasound first. Okay, yeah.
In pediatric, actually, majority of the diagnosis can be made by ultrasound. Okay, when you go into clinical, when you become the houseman, the medical officers, try to go for the something simple first for your investigation, something less invasive and something less radiation. Okay, right. Thanks, Erica. I would like to invite our pathologist, Hafiiz.
Thank you, Ms. Marjmin. Good morning, everyone. I'm going to present on my part on histopathological findings. So we received the first biopsies from the unstained slide from private hospital. Biopsies taken from terminal ileum, appendix, and omentum. And the second biopsies is repeated after the surgery, and it's multiple biopsies taken. So this is the first biopsies that we received unstained slide from the private hospital, which the first pictures here shows the terminal ileum. It composed of intestinal mucosa and lined by the intestinal villi. And from these higher low magnifications, we can see there is a deep fissures that's extending up to the muscularis mucosa. And it is lined by neutrophils and also fibrin depositions and also debris. And adjacent to these fissures, there's mucosal edema. You can see at this picture here, there's edematous mucosa and submucosa. And next to it, the uninvolved mucosa, it is there is no distortions, no cryptitis or crypt abscess next to it. And this is sections from appendix. It shows here there is a focal mucosal ulceration seen with transmural neutrophilic infiltrations, which we can see the neutrophil infiltrations from the mucosa up to serosa. And there is, in these sections, actually shows there is a marked neutrophilic infiltration seen at the serosa, marked serositis. Therefore, the first biopsies that we received, we concluded as acute enteritis with perforations, and the appendicitis with acute serositis. For the omentum, these pictures here, fibrofatty tissues infiltrated by neutrophilic infiltrations. And therefore, we conclude as serositis, acute serositis. There's acute inflammations going on. This is the repeated biopsies that taken after the surgeries from the multiple sites. So from the terminal ileums, it's taken from 5 cm from the stoma and also 15 cm from the stoma site and also enteropistula site. So basically, when we receive the biopsies, we receive limited superficial fragments of intestinal mucosa that lines by intestinal villi. And in the lamina propria, we can see there's neutrophilic infiltrations. In some areas, there's cryptitis, but no crypt abscess seen. However, there is no granuloma or dysplasia seen. So this is the biopsies taken from the colon. This picture shows fragments of colonic mucosa lined by colonic columnar epithelium that composed of round tubular crypts and glands. If you can see here, the architecture is quite preserved and the glands are actually well spaced, and mildly the lamina propria is mildly infiltrated by lymphocytes. Otherwise, throughout the colons, we didn't see any granulomas, dysplasia. And the finding is quite non-specific. As we can see from here, there's occasional neutrophils infiltration seen in the lamina propria. It may indicate there's some acute inflammations going on. So Sam as well seen from the rectosigmoid that nothing much we can see. There's crypt and architecture preservations and mildly infiltrated by mild to moderate lymphocytic infiltrations. Otherwise, there's no granulomas or dysplasia, or we can see some of the colons may associated with lymphocytic aggregates. And samples also taken from the stomach. This is fragments of tissues that compose that lined by fibular epithelium. It composed of mainly oxyntic glands that lined by parietal and chief cells. The lamina propria is mildly infiltrated by lymphocytes. And these sections taken from the pylorus, it's again lined by fibular epithelium that mainly composed of gastric glands, which is lined by the mucous neck cells. So we know that the sites of origins of this biopsy is actually taken from the pylorus. So from the higher magnifications, we can see the lamina propria is mildly infiltrated by the lymphocytes and no dysplasia, no evidence of H. pylori infections or granuloma seen. So from duodenum biopsies, these sections, it's taken from the small intestinal mucosa. We know that from the architecture here, we can see it's lined by intestinal villi, which is lined by the columnar epithelium with interspersed with goblet cells. Otherwise, the crypts and glands are not much distortions occurs, and the lamina propria is mildly infiltrated by the lymphocytes, plasma cells, and occasional eosinophils. Otherwise, there is no granuloma or dysplasia. So, what are the assessment we are looking for in the histology is that there is any activity or chronicity. So if there is neutrophils infiltrations, that might indicate there is some acute inflammations going on. We can see from this picture, the neutrophils is surrounding the crypts, and we call it as cryptitis. when there is neutrophil exudates in the lumens, it is forming the crypt abscess. So basically, if there is activity, we will conclude that there is active inflammations going on. Whereas for the chronicity, because of the chronic inflammations going on, it can cause crypt architecture distortions, which we can see for the long time. It can cause the crypts become shortening. We're looking for crypts branching, drop out, loss of crypt parallelism or villiform surface. Other than that, we're also looking for the basal lymphoplasmacytosis. This basal lymphoplasmacytosis is referring to the where normally in normal mucosa, the crypts and glands, it will be like a test tube that lying just touching the muscular mucosa. But if there is a basal lymphoplasmacytosis, the space will be expanded and infiltrated by lymphocyte and plasma cells. And other than that, we're also looking for Paneth cell metaplasia and hyperplasia, because this is a part of the cell adaptations due to the injury, and these cells can undergo metaplasia. Other than Paneth cell metaplasia, we're looking for pyloric glands metaplasia and lamina propria and submucosal fibrosis. So again, this is in cartoons, I'd say. This is the basal lymphoplasmacytosis that I mentioned before. So in normal colonic mucosa, the crypts is usually like a test tube that almost touch the muscularis propria, but when there's a basal lymphoplasmacytosis, they will be expanded. So our final conclusions from the biopsies taken from the repeated biopsies, it is quite non-specific. So we concluded as a chronic active ileitis and also colitis and proctitis. So specimen from the previous biopsies, the initial biopsies, shows patchy areas of inflammations and some areas of fibrosis with underlying muscularis propria. So significantly, these patchy areas of involvement are separated by uninvolved bowels. So chronic IBD changes typically of adults' Crohn's are not seen in these patients. So histologically, changes in pediatric IBD can be subtle and non-specific. So the second biopsies that we taken are only showing colitis, but may still represent early IBD. Because in early IBD, the architectural distortion might not be present. But in Crohn's disease, the architectural is less prominent than ulcerative colitis. So in ulcerative colitis, chronic active inflammations in the rectum, it's normally proceeding proximally in continuous and diffuse pattern. So typical findings in chronic active colitis, it is limited to mucosa and superficial submucosa with ulcerations. And you can see deeper inflammation with severe fulminant colitis. We can also have increase in inflammations in cecum near the appendiceal orifices, which we call as a cecal patch. And we can have inflammation in terminal ileum as a backwash ileitis, which due to the reflux from the colon content. So in Crohn's disease, it is usually patchy transmural chronic active inflammations in any parts of GI tracts. And the typical findings we are looking for is transmural inflammations. Transmurals mean the inflammations can be seen from mucosa up to the serosa or deeper layers, and skip areas and patchy inflammations. So that's why multiple biopsies is helpful to see the patchy patterns of the inflammations. And granulomas and also ulcers can be seen in Crohn's disease. It can either be a superficial abscess to fissurings, muscle and nerve hypertrophy, pyloric glands metaplasia, especially in terminal ileums, fibrosis and strictures, and also fistulas. For that, I'll stop my presentations.
Thank you, Dr. Hafiiz. Okay. Dr. Hafiiz highlighted the differences between ulcerative colitis and Crohn's disease. Okay, you guys have to know very well because that's usually the exam question. Okay, Muhammad, Prof. Muhammad agreeing to that. Next question, Muhammad bagi dalam dia punya KFQ. Okay, without further ado, I would like to invite Dr. Ong Sik Yong from Hospital Tengku Azizah, HKL. Thank you.
A very good morning to ladies and gentlemen. Thank you for having me here today, and a special thanks to Ms. Marjmin for the invitation. Really honored and humbled to be here presenting to the audiences. So in the next 20 minutes, and hopefully it's only 20 minutes, that actually what I'm going to cover is actually firstly, I will update the case progress after the patient actually has come to Hospital Tuanku Azizah. And at the same time, I would illustrate how would they plan a management strategy for a child with Crohn's disease or inflammatory bowel disease, and particularly the challenges that lies ahead of this patient with such a complex disease. And to round out the presentation, I will do a discussion on inflammatory bowel disease in children, which by itself is actually a large topic, and you need days of seminars on this topic. But our focus today, which I think relevant to this patient, is on monogenic IBD. So I see the majority of the audience are undergraduate students, so I hope I don't bore you down. So just to recap, before we lost ourselves in the patient's progress, so we have this 8.5-year-old boy whom actually was very thin to begin with, but he has no significant past medical or surgical history. So he caught what seemingly straightforward hand, foot, and mouth disease in October 2022. And in a week time, the oral ulcer persisted. Then he had perianal boil. Then he developed acute abdomen and fever, only later to found to have multiple perforation over the terminal ileum. That he was then subjected for a laparotomy and a ileostomy. So many among the audiences who have thought this is the worst one would get for an 8.5-year-old boy, but things just go even downhill further and got worsened. So as illustrated by Asmarina just now, so the laparotomy wound decided to give way with past discharge, and what you see is actually the enterocutaneous fistula arises from the ileo, which is the very active disease segment. And at the same time, you can see the ileostomy wound here, that the age of it actually started to give way as well with ulcers. And the ulcers just get deeper and wider with time, and concurrently is having recurrent fever as well. So the endoscopy then revealed that actually indeed the upper GI was involved with duodenitis. And MRI later also found the inflammatory changes involving many areas of the ileocecal valve, cecum, ascending colon, in a skip manner. So at this juncture, anyone who actually has read about inflammatory bowel disease or managed such cases would have thought that it all ties up to a case of Crohn's disease in a poor child, isn't it? But managing children for the past few years with inflammatory bowel disease, we know there are many IBD mimics, meaning there are other diseases that looks like IBD, and vice versa, that actually IBD might mimics other disease. So, and furthermore, in the case where they come with very atypical presentation, we will be very cautious before we just label a child such as a Crohn's disease. So we decided to take a step back and then cast our net wide to see what are the possible differential diagnoses. And to begin with, for a child to come with acute GI perforation after neonatal period is actually not common. But the least of the differential can be a long one. But in this child, obviously, there's no trigger such as trauma, mechanical issues, or even chemo, radiation therapy to account for the intestinal perforation. So we then narrowed down our differential diagnosis to this list in front of you. So top the list is still inflammatory bowel disease or Crohn's disease. The point towards that would be because of the bowel inflammation with skip lesion and with negative infection screen. Of course, we have the wisdom of hindsight that actually when the patient came to us, it's already 2 months down the road that we see the disease progression with enterocutaneous fistula, that we know, oh, this is likely a case of Crohn's disease. But what is not in favor of Crohn's disease actually a rather acute presentation, knowing actually inflammatory bowel disease often come in chronic presentation. So in a week time, this child birth is bowel, so this is actually rather atypical. But having said that, it's not that we have not seen before. In our case cohort in HTA, we have 2 similar presentation in children that currently receiving biologics for their Crohn's disease. So moving on, the second that came quite close to Crohn's disease would be GI vasculitis. So GI vasculitis, I think the one that you are more familiar with is Henoch-Schönlein purpura. Not sure whether it rings a bell. So Henoch-Schönlein purpura is actually where there is immunoglobulin A mediated inflammation that caught the GI segment. The less common one, myself actually has limited experience, would be something like ANCA-associated vasculitis, polyarthritis nodosa, or Bechet syndrome. That actually can come also with bowel inflammation with perforation. But the thing is actually we search high and low, we can't find any other systems involvement in this child. So meaning being an isolated GI disease, perhaps we might need more sophisticated tests like CTA, perhaps computed tomography, angiography, to catch the pathology over the vessels, which we have not done at this moment. And moving on, the third one, infectious enterocolitis, which is a more common and easy diagnosis, one would actually guess, which can come with acute abdomen and bowel perforation. But the negative infection screen and the fact that actually there's colonic skip lesion and enterocutaneous fistula make this diagnosis less likely though. And if you move downwards, tuberculous ileitis, meaning secondary to tuberculosis, we know tuberculosis is actually a great mimicker. They can mimic any other diseases. And especially in this case where ileocecal valve or involvement is present, which is an area liked by tuberculosis where there are a lot of lymph nodes. So that would be something that we need to consider. So that's why actually we were looking hard for this tuberculosis, but there is no history of TB contact. There's no pulmonary disease to begin with to say this is a secondary focus. And the TB workup that we've done so far actually were negative. That includes a MON2, PCR, even histopathological examination of the endoscopic biopsy, including a repeated one, did not show evidence of tuberculosis. So after this slide, then one would have thought that, okay, this is then the disease that we need to focus on, inflammatory bowel disease. You will know later on that perhaps this is too early to say, but then for now, we'll just fix on inflammatory bowel disease for this poor child. So before I went on and say what actually we do for this child, so then I will illustrate how we who manage pediatric with IBDs design management strategy for children with Crohn's disease. So the goal in treating patients with IBD is always like any other chronic illnesses in pediatric patients. So eliminate symptoms of abdominal pain, diarrhea, and restore their quality of life. And more importantly, actually to restore normal growth, like mentioned by Ms. Marjmin earlier, that important to get them back to their growing potential. And at the same time, eliminate any complication that we have already seen arises in this patient, which is enterocutaneous fistula. By using medication, but at the expense of the side effects. So we need to minimize on the drug toxicity. So when you manage IBD, people always look at what is the treatment goal or target. Are we happy that actually clinically the patient is well, but yet radiologically, maybe when you do a scan, you can still see the bowel inflammation, even though patient might not feel it. And when you do an endoscopy and you do a biopsy, then you will still detect the disease activity. So a lot would say, why not we just stop at clinical remission and rather not going too far with the expense of the medical toxicity. But reports and evidence over the years have shown that actually endoscopic remission should be the one that we're looking for. Meaning if you repeat an endoscopy on the same child, you would expect the wound and the inflammation to heal completely. And with this endoscopic remission is actually the one that's associated with less risk of relapses subsequently, knowing inflammatory bowel disease is a chronic relapsing condition, and you have less surgeries, hospitalizations, and if a child is actually put on steroid for the induction treatment, then it's easier to wean them off with endoscopic remission. And the principle of treatment, Perhaps many know better of nephrotic syndrome. So nephrotic syndrome is also something like inflammatory bowel disease. They are chronically relapsing condition. So you will need to induce them into remission and then maintain the remission with medical treatment. And the choices of treatment actually can range from exclusive enteral nutrition all the way to surgery in inflammatory bowel disease, not nephrotic syndrome. So if you decided to use exclusive enteral nutrition, something perhaps you're not familiar is actually when you decided to use this treatment, a child would only be able to drink milk for a good 6 weeks, no other food intake. It's indeed a challenge to do this treatment in our children, but we have successful cases that actually has went through this kind of treatment. And some might choose antibiotics, steroids, or now moving forward, actually people try to avoid steroids. And what is in favor now is actually using biologics. In particular, children will be using anti-tumor necrosis factor alpha. But not to mention and not to forget the surgery, the role of surgery when it comes to refractory cases to medical treatment. You will get more complex and complex down the road. So then telling you the goal, the choices of treatment. So then coming back to this patient, actually, how do we then choose which treatment for this patient? So we are provided with the wisdom from IBD experts around the world, and this is actually taken from the ECHO and ASPERGAN. ECHO stands for European Crohn's and Colitis Organization, ASPERGAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition. So actually what they provided, a guide is actually, if you look at this table, you will be able to re-stratify a patient according to, one, their disease behavior and whether there's any risk factors. They stratify them to see whether they would predicted to have a poor outcome or not. So say, for instance, if you look at the top left corner, if you are a B1, for example, then you just have inflammatory changes without strictures, stenosis, or any penetration like fistulas, and there's no risk factors additionally, then this patient would then be a low-risk patient. They would likely to respond well to treatment. The patient would not have very early relapses. So then exclusive enteral nutrition would be the treatment to go. But if you look at our patient, then unfortunately actually falls to B3. B3 means actually they have not only inflammation, but they are already starting to penetrate the bowel wall to cause fistula. So this is a high-risk patient that you know if you use conventional treatment, the chances of early relapses and the resistance to treatment is very high. So the recommended induction treatment would then be a surgery if required in combination with a post-operative anti-tumor necrosis factor therapy. And something perhaps new or you might come across before using biologics. Biologics is actually the component that you derive from human body, then actually use that actually against a human antigen as a drug treatment. So biologics are used in pediatric IBD is actually not something new, just like rheumatoid arthritis and so on and so forth. And the most widely used would be infliximab or adalimumab. These are the antibodies towards tumor necrosis factor alpha. Tumor necrosis factor alpha is the pro-inflammatory cytokines that drive the inflammation in the mucosa down to the muscle layer in inflammatory bowel disease. So if this tumor necrosis factor continues to go on and work on the bowel, that will cause ongoing inflammation and impair the tissue repair, say after an infection, and it will go on and on. So by giving these antibodies, it will halt the inflammation and hope to heal whatever lesion that the patient has. Of course, using this medication is not without any risk, with the expense of very small risk of serious infection, if especially used concomitantly with immunosuppression like steroids. There are other side effects as well, like lupus-like syndrome, meaning after you use this medication, someone might actually triggered to have a lupus-like syndrome, and also infusion reaction, which can be monitored and proven to be quite safe. And over the years, actually, with using biologics in children with IBD, we always extrapolate usage of drugs from adult. Then we know how to actually use according to the adult experience. This is the same for biologics in IBD in children, but over the years we know with the personalized medical care that we now don't follow a fixed regime. It used to be certain drug dosages by 0 to 6 weeks of regime, but now we actually are moving away from that, because every patient pharmacokinetics to biologics will be different, meaning they metabolizes the drugs given to them differently. Some actually cleared from the system very fast, then they won't be having the medication in their body. So then ideally, if you started a patient on medication on biologics, you would then need to check on the medication trough level to see whether the body still contain these drugs to have a effective response. And the algorithm now is actually very clear how to guide us through to use treatment. And this is what we do, coming back to this patient, so that we decided that this patient would require IV infliximab, the anti-tumor necrosis factor, TNF-alpha, with no added immunomodulator in the beginning. So he actually has gone through total 9 doses of this infliximab of 100 milligram. If you remember, his weight is about 13, 14 kilos. So this is about 7 milligram per kilogram, given at a weekly interval, which is actually very intensive. And when we actually check his infliximab trough level, it's actually 5.9, much way below 20 that we aim for. So doses was actually increased to 200. And you can see later in the illustration of his disease progression, we intensify it to weekly instead of maintenance on 4 to 6 weekly. So to finish 9 doses in 3 months, actually a very intensive course of treatment for this patient. So for biologics to work, actually nutrition actually goes hand in hand. So in those who actually malnourished, actually biologics can't really work very well. So nutrition rehabilitation would be something that we would actually aggressively act on. So when he came first, actually the stomach output was still watery. So he was put on parenteral nutrition for 2 weeks, ended prematurely, that actually because the PICC gave way. You can see actually his body weight for the first time he arrived in HTA, he was 13.55. So within 3 weeks of biologics treatment and also the parenteral nutrition, his body weight does go up to the highest 14.8 kilogram. But what happened after that, for the next 2 months, his weight just dropped dramatically to even below what he first came with. So he was 13 kilogram early of this month. So the question comes actually, what goes wrong? Whether the disease actually still is very active and ongoing in the bowel, or whether there's the wound around the stoma, which is very actively ongoing that actually causes a lot of energy consumption, or there's any other things that's going on. So it's very important to monitor the patient's progress when you give treatment. And monitoring can be in the sense of clinical, radiological, endoscopy, and also histology. So how do we monitor a patient with Crohn's disease when they are given treatment? So clinical markers will be actually surrogate to endoscopic remission. Remember, we said endoscopic remission is the one that we target for, but we can't be doing endoscopy every week we see him. So clinical biomarkers would be things that we will use as a surrogate to whether the patient actually has gone into endoscopic remission. So this is what we call the Pediatric Crohn's Disease Activity Index, something good to remember, PCDAI score, where this is a scoring system where they include history taking for a recall of 1 week, whether the patient still have tummy pain, functional well-being, what's the bowel output, combined with the physical examination, what's the weight doing, whether they are growing taller, abdominal examination, perirectal and extraintestinal manifestation, all the way to the laboratory investigation. So you combine all this and you score them. A score of less than 10 would mean that actually your treatment is successful to bring them into remission, which is the aim. So if you look at this table, from the time he came to us until 5th of May, after 9 doses of infliximab. So in the beginning, as I said, after the 2 doses of infliximab, you see his very high CRP of 113 can only manage to come down to 77.5. And his PCDAI score then come down also to the lowest at 10. And it can't go down any lower than 10. That actually, even though you intensify subsequently to weekly infusion of infliximab, you can't go any lower than a CRP of 70 and below, and PCDAI score less than 10. So that's when we decided to have a look again and see what is going on, whether the bowel is still so active with an endoscopy and using an MRE, a repeated one in our center, to see whether there's any collection elsewhere that might be the reason for the high CRP and poor PCDAI score. So a repeat endoscopy in our center on the 23rd of March. So the upper endoscopy compared to the one that he had first was normal. And if you look at the ileoscopy, meaning actually we scope him through the stoma to look at his ileum, and colonoscopy through down below from the anus all the way up to the ileocecal valve. So what you can see is actually this is a normal ileum, normal ascending colon, transverse colon, descending colon, all the way to the rectum. So meaning actually this patient actually has a very pristine endoscopy appearance. So then we took biopsy to see whether microscopically actually whether the patient is also in remission. So then what we found was the upper GI and lower GI endoscopy biopsy were all showing a very quiescent disease. So then question comes, why this patient is still losing weight and why this patient's CRP is still sky high even with this infliximab treatment? And whether the patient is actually having any opportunistic infection when we actually put this patient on so high dose of treatment. But endoscopy and our workup actually showed there's no identifiable granuloma to suggest add-on TB infection or any CMV that might happen or EBV infection that might happen when one is actually on this immunosuppressive treatment. And the MRE that follows a month later show, in fact, whatever disease or inflammation that we see has all improved, leaving some residual distal ileum thickening. And of course, we are not expecting the fistula to close so soon. We have evidence that actually from children who have fistula, it will actually take months to a year for the fistula to finally close with treatment. So this is not a surprise. But yet there's no intra-abdominal collection. So we are basically left clueless and getting more interesting that what actually is happening. So we would then look out for whether this patient is actually having any immunodeficiency for such a poor wound healing and continuous inflammation. So the serial FBC, if you have gone through a PID lecture, then you will know, you will look out for whether this patient has any neutropenia, lymphopenia, or eosinophilia to say. And whether they have low immunoglobulin level. This is a gamma globulinemia, but gamma globulin is actually very high. High is 16 and above, this is 22. We were also considering whether this is a case of chronic granulomatous disease where wound healing is very poor, but he has a normal respiratory burst. The retroviral screen were normal as well. So as the chest X-ray looking for any inflammation elsewhere in the body. Whether this is a connective tissue disease, apart from that drives behind the inflammation in the bowel. Rheumatoid factor were normal, ANA was positive in a titer of 1 in 100. We were excited when we saw, ENA is positive. We quickly ring our rheumatologist in Selayang and say, hey, you probably have this case that is yours and not ours. But of course, they say, no, this is not, because just can't diagnose a child with SLE or any rheumatological condition just by a positive ENA. Why not you send an ANCA? Perhaps it's an ANCA-associated vasculitis, GI disease, but ANCA then came back negative as well. We look high and low, look in the eye for uveitis, scleritis. We look at the urine repeatedly to see whether there's any nephritis, and we can't find any other else of foci apart from the history of GI inflammatory disease. Up to this point, I don't know, I'm not giving you a happy ending, unfortunately, and work is still in progress for this child. So this is an 8.5-year-old boy, ileocolonic Crohn's disease at this point, complicated with enterocutaneous fistula and a peristomal ulcers, and this is what he is now. What we are facing now is actually he has a persistent active disease that from endoscopy, radiology looks very pristine, but yet the inflammatory markers and the weight actually is not doing good. Something is not right. And we are still in search of perhaps any bright ideas from the audience. So he actually has a partial response, I must say, to the anti-TNF alpha. And we have even subjected him to an additional exclusive enteral nutrition to try to soothe the inflammation, but he can't tolerate more than 2 weeks. Next would be to add on immunomodulators. Something would be very cautioned when he's actually very malnourished, so that we actually need to work very hard on severe acute malnutrition that he has. As illustrated by Asmarina, actually the BMI is dropping and dropping. So one thing that we probably need to do is actually perhaps get him in for a parenteral nutrition on top of whatever enteral nutrition that he's having. So then to build him up, we might lose him if he caught a severe infection when he's so severely malnourished. Of course, we always revisit whether we are getting the right diagnosis. So inflammatory bowel disease is actually at the surface, but whether what drives the inflammation behind the bowel being inflamed, whether this is something vasculitis, or that brings us to my discussion, which is whether this is a monogenic inflammatory bowel disease, that we have already sent off his genetic tests to Korea and to United States as well to see whether he harbors any gene that might click and tells us the answers to his disease. So briefly, this is the last part of my presentation. So inflammatory bowel disease, you have seen in adult, but Perhaps you have not seen many in this hospital, but in places like HTA or UMMC, actually we have seen a cohort that hundreds of patients with children with inflammatory bowel disease. So condition that characterized by chronic inflammation, which is chronically relapsing, that involve the GI tract. Subtypes that we all know are Crohn's disease or ulcerative colitis, but another third group will be IBDU. So IBDU is actually when you can't classify into whether they are Crohn's or ulcerative colitis. And that's actually the harder part when you can't seems to design the treatment because they are less well studied. So what actually drive inflammatory bowel disease? I think over the years, people have thought inflammatory bowel disease is actually a Caucasian or white people disease. But for information, since the 1950s, when China reported their first ulcerative colitis, we are seeing rising incidence. And so as in this part of the world and Malaysia. So question comes, why this actually has spread all over the world and not only to Caucasian. Definitely genetic susceptibility play a role, meaning one would have perhaps a certain gene that actually tells you have a risk of IBD, but you might not have the disease until you are exposed to certain environmental factors that we know now. Urbanization is actually the key behind that drive what we call intestinal dysbiosis. Intestinal dysbiosis is actually when the microbiota in your gut normally is actually at the homeostasis. They are very happy. But actually when they are provided not the good factor, certain microbiota just go haywire, and then they actually what we call dysbiosis. There are imbalance of certain good one and overdrive of the bad one. This is what we call intestinal dysbiosis that then drive the patient to a dysregulated immune response. Then there's ongoing inflammation, and infection, after which the inflammation is supposed to heal whatever part of your body. But when infection is gone, this inflammation is ongoing, what we call a dysregulated immune response. So this is what we believe now as the cause of the inflammatory bowel disease. So what makes it so special when a child gets IBD? We know actually IBD can happen at any age, from as young as a neonate we have seen, of course to the elderly that is not in my range of my customer service. So, but the peak age would be young adulthood. If a question comes, what is the peak age? Would be 15 to 29 years old. But what we found now is actually a younger ones get IBD, the role of the genetics is actually getting higher. Hence, they will have higher affected first-degree relatives. Their disease course will be worse, and worse still is actually they have high rate of resistance to treatment, perhaps that one we see in this patient. So again, this is to illustrate what I mean, the genetic factor. So in conventional IBD that you see in the gastro clinic in HUKM, that is what we call the polygenic IBD. Meaning, so far, the genome-wide association study has found so many genes that might be responsible for the IBD. But having this gene wouldn't mean that you will have the disease. You have to have the environmental exposure. So this is a polygenic disorders, very heterogeneous. But in pediatric world, as one get younger, you might then catch a gene that is actually the cause of the IBD. And having this gene means definitely you get IBD. And these are the disease that also has primary immunodeficiencies. So why do we need to know monogenic IBD? Because they behave so differently from the polygenic IBD that adult manages. And the phenotype is different. So as I mentioned, those IBDs actually we cannot classify into either Crohn's or ulcerative colitis. And unfortunately, quite a large group of a patient belongs to this IBDU. So when we know Crohn's, so these are the treatment regime. When you know this is ulcerative colitis, this is the treatment regime. But when it comes to IBDU, they are not either Crohn's or ulcerative colitis. So then the treatment regime becomes very odd. So this is very difficult to begin with. And of course, the outcome, because of the association with immunodeficiency, they have higher morbidity and also mortality if not treated. And treatment option, as I mentioned, in IBD, you can use biologics. But biologics is not the answer or holy grail to every IBD that you know. Anti-TNF alpha, even though so widely used, but bear in mind it might be contraindicated in certain IBD secondary to chronic granulomatous disease. Fortunately, it's not in our patient. And if your patient is an IBD secondary to a interleukin 1B receptor antagonist, say for example, this, not to bore you further, MVD or CGD, so then that produces a lot of IL-1B, then anti-IL-1B would probably be the answer rather than this anti-TNF alpha. And people have done transplant for IBD, inflammatory bowel disease. Of course, not bowel transplant, but it's actually the stem cell transplant or bone marrow transplant. meaning actually you want to overhaul the immune response to actually get back the normal bowel. But of course, also not an answer to every monogenic IBD that we know. And of course, monogenic IBD actually have their own set of complications different from this polygenic IBD. Say, for example, those with XIAB defects, they would have predisposition to EBV infection. Some of them actually would have actually tendency to get blood cancers as well, or skin cancers, such as those with Hora-Radisson syndrome. And very importantly, if young couple with this kind of unfortunate child, then genetic counseling comes into play when you inherited certain gene, whether you happen to your subsequent offspring as well. So as of note, just to share actually the list of these monogenic IBD is getting wider and wider without us knowing, and already 90 genes actually has been identified, and all these come with IBD. And the gene that might be, there are so many genes that actually you can't even, myself actually can't remember all these findings and extra-intestinal findings for many particular gene, but we are suspecting that perhaps the patient that we're having is actually having an autoinflammatory disorders that might need a different strategy that we are using genetic testing to capture and see whether he indeed inherited such gene. So going briefly on clinical presentation, I think for undergraduate purposes, I think by now people wouldn't have a problem to identify a case or suspicion of IBD. So classical symptoms of IBD would be someone would come with parietal bleeding, abdominal pain, diarrhea, weight loss, associated with growth failure. So predominant symptoms would be rectal bleeding, abdominal pain, diarrhea. These are the classical IBD presentation. But we know there are patients with IBD that come with non-classical predominant symptoms. So this patient, I don't have a pointer, but that comes with laparotomy for acute abdominal pain. They just come acutely as this kind of presentation, and they actually turn out to be an IBD. So, and we have also seen patients who come with just recurrent oral ulcers, recurrent perianal lesions, skin lesion that turn out then when you scope them, actually you found more lesion in the intestinal tract. And there are many other extra-intestinal manifestations. The one bold in red are those less in common, right? So then, if we suspected that this poor boy is actually an inflammatory bowel disease that refractory to any treatment that we gave, whether he's having any form of primary immunodeficiency, perhaps an autoinflammatory condition. So these are the clues that you probably want to look out for, whether he has such, those who have PID would have such comorbidities on the left, yeah, and or whether there's any specific physical findings on the right that actually might suggest. Trust me, actually we have looked through this list, and the list on the right, he has none of those, disappointingly. So we are still losing our hair and scratching our head that actually we can't seem to find an answer. So sorry for no happy ending for this patient. Again, work is still in progress. So I hope I show you the challenges in actually defining IBD in children. Of course, I would like to send you a case of classical IBD that we managed and show our successes, but in life, actually, we don't have successes all the time, and these are the challenges. And hopefully, when people talk about IBD, the concept has changed that in children, now we look out for monogenic IBD, where there's a gene defect that you need to identify. And this is the case that we're talking about here today. And of course, I've also briefed you through what is the treatment strategy when we plan for a child with inflammatory bowel disease. How do we decide treatment for a patient with Crohn's disease? So with that, I thank you and welcome any questions.
Okay, as you can see, Dr. Ong highlighted a very important issue that it's not easy to diagnose this patient, and we are still going nowhere in terms of the management. So, of course, if you learn, the inflammatory bowel disease usually are the typical one, the one that you can say that these are the treatments, okay? We are highlighting these cases because it's difficult in terms of initial diagnosis, and also after we make the diagnosis, we still clueless in terms of the management. For the surgical part, I still cannot do any of the closure of the stoma or the fistula because of the issue. We do not know what's going on with the child as yet. Okay, but for the undergraduate, at least we hope you can learn for the fistula at least about the management of SNAP, that you look for the sepsis, you look for the nutrition, you look for the anatomy of the bowels, and you look for the causes. Okay, so any question regarding? I know. If not, yes, Azizi. Azizi has question.
So this is a good example where modern medicines fail.
Sorry?
This is a good example where modern medicine fail.
Yes.
Yes.
Maybe
So
kena try traditional medicine.
basically, what we can conclude from this session today, probably there's a genetic cause, and we couldn't find it until now. Even if we find it, there is no cure for it. Number two, there's a possible bowel dysbiosis, which is tried to be tackled by total enteral nutrition, which contain dairy product, which is by itself inflammatory to the bowel. And the third one is unregulated immune response, which is tried to be controlled by TNF factor, blah, 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 which is we are trying to control the cytokines to reduce the inflammation that are affecting the bowel, basically. So I'm just wondering whether this is a part of the disease, because we are the third and fourth generation after the food industrialization. We are forced to eat sugar and flour. So basically, we see a lot of mitochondrial heteroplasmy. So, and as our descendant continue to be to be created, so the degree of mitochondrial heteroplasmy is increasing until we reach that 70% or 80% of mitochondrial heteroplasmy, where we see our gut bowel cells start to fail, where they present with severe ulcer at a very young age. Number one. Number two is probably we need more aggressive measures to control the gut dysbiosis. Probably it is time for us, even though it's not proven scientifically, this GAPS diet, this gut and psychology, something GAPS diet. So basically there are a few stages. This is the extremes measure where we try to control dysbiosis, elimination processes. Stage 1, second 2 is reintroduction of full GAPS diet, and a reintroduction of dairy proteins, whatsoever. And the other thing is whether we need a non-conventional way of tackling this the immune systems. So instead of using all these biologics, so the other kinds of reducing inflammation in the body, like using photobiomodulations. I think these are just some ideas that we may have to explore, because apparently all this evidence-based medicine, that's a proven treatment in other patients doesn't work in these patients.
Okay, thank you, Prof. Azizi, for the suggestion. But I guess it's a bit difficult for children because there are not a lot of studies that can prove either or. Okay, we can try according to what we have known from the studies that being done, because there are also safety issues that we have to think of. And in this boy, unfortunately, we cannot keep them in the hospital all the time for the TPN just to rest the bowel. So we still have to figure out how to for them to live the quality of life at home, and at the same time trying to balance that. Maybe Dr. Ong have idea?
I think thanks for the comment. I think the problem or the trouble that we have in this patient now is actually we don't have an ultimate diagnosis. As much as we like to have inflammatory bowel disease, very straightforward, then you give treatment and they respond to treatment. But in this child, when a child is refractory to treatment, that's when we need to look for the primary diagnosis. So whether there's any genetic defect, what we call primary immunodeficiency that we see more in children that present as an inflammatory bowel disease. So if we then use genetic studies and we found a certain primary immunodeficiency, I'll share with you the whole list, then the treatment will go according to what primary immunodeficiency the patient has. So say, for example, you find this patient to have a severe combined immunodeficiency, then immunoglobulin would be actually the things that you give the patient to replace the antibody deficiency. If you find this patient to have very high autoinflammation in actually the body system, then perhaps more wider immunosuppression would be like, say, steroid, unfortunately, to be actually put on this patient. Response to dysbiosis. I think you go to any pediatric talks nowadays, nothing goes back home without talking about microbiota. You can just buy off the shelf probiotics that actually maybe your niece and nephews are taking day in, day out, don't know promote for what kind of health. But probiotics actually has its days in inflammatory bowel disease in children. In fact, people talking about fecal microbiota transplantation, meaning actually they harbor the good microbiota and then they put into the patients. Of course, not through orally and sometimes through rectally. But fecal microbiota transplantation in children actually is still more work to be done at this moment. We don't have solid evidence for us to go with fecal microbiota. But diet actually is something that we can actually think of. We have tried exclusive enteral nutrition. It's not that we not try, but it's not easy. I ask any one of you to just drink milk for a good 6 weeks. Imagine. You might do it for 1-2 days and the child actually happily complies, say, I can. By the end of the first week, our human nature instinct of being biting, I think is actually there that we will give up by the end of the first week and he actually can't go through the 2 weeks. So it's not easy. And now actually advances in medical treatment, now actually we go by exclusion diet. So and I think too much to talk in this half an hour lecture. That people actually do Mediterranean diet. You only eat certain things and take away certain things that are pro-inflammatory. These are designed diet for patients with Crohn's disease. So to cut short, I think this patient, we are still having diagnostic dilemma and we actually harbor a lot and put our bet a lot on these genetic studies that is yet to come back. Perhaps Ms. Marjmin actually might update later on that actually we found anything in the genetic study, hopefully. Yeah.
This child is actually a very matured kid for the age. Okay, he's very compliant. He doesn't cause much trouble. So at least we do not have the child, like kicking and screaming and don't want to follow your instruction. This kid followed every single thing. But then again, it's not an easy management and it put a lot of impact to the family as well. So these are the problem when we cannot do our best to see what are the problems and how to manage the child. Okay. With that, I hope give you some insight to what you are going to face with when you become a clinician one day. That not everything that you learn and that easy to handle when you become a doctor. You know that you have a limitation. You know that there are some knowledge that you are not yet known to you. Okay. All right. Without for that, I would like to conclude this CPC for today. And I think there is a Kahoot, isn't it, for the student? Okay, you are quite familiar with the Kahoot, so that's the number, right? Okay, everyone ready? We can start now. Tak lagi. Okay. Okay. Dr. Mohamned usually has by the end of the year ada hadiah untuk dia orang. Huh? Okay. I think kalau my postgraduate dia jawab tak tahulah. The question is easy. Saya nak menunggu habis ni. So So many. Boleh kot start. I think we can start now. Okay, first question. Okay, inflammatory bowel disease, which include Crohn's disease and ulcerative colitis. So, what are the appearance of the Crohn's disease and not ulcerative colitis? Is it right? Second, distribution of Crohn's disease. And the third, what are the most common extra-intestinal manifestation of IBD? Ada soalan jawapan bocor tadi Dr. Ong bagi. Siapa nombor satu tu? A1793889. Tak ada nak mengaku. Okay, tak apa. Thank you for attending.